Our next speaker is Dr. Erik Munson from Marquette University's MLS program, and so he's going to lead us through talking about the multitest syndromic panels and critical thinking.
All right. Thank you very much for the invitation to speak to you today. Can I walk around?
Sure.
All right. Thanks for the invitation to speak to you today. It's great to see some grizzled veterans in the audience, such as myself, as well as some newcomers, and we really appreciate laboratories letting you loose to come join us today. Second thing toward Erik Beck, yes, I do have ornithine decarboxylase tubes in my laboratory, and on top of that, I have base controls, right? And the base control is important because it has that little sliver of glucose, and this should have been an iClicker question, why do we have glucose in a decarb tube? We can talk about that after lunch. Okay, then the third thing is that I am not here to preach law and gospel about my topic. Hopefully what I present to you will maybe trigger some commentary, either if we have time at the end or during our, half hour, 45 minutes lunch break or whatever we have next. So I am not here to preach law and gospel, but to try to present both sides of a potential argument to the audience. So, as I've sat here throughout the day,
Just hit your screen on the computer once, just touch it, or and then...
Seriously? Don't punch it? Okay. Oh, there. It worked before, and I screwed. Oh, thank you. All right, so as I sat in the audience, I was thinking that, the basic components of delivering a laboratory result involve pre-analytical, analytical, oops, that's pre-analytical, I'm going backwards. Pre-analytical, analytical, and post-analytical. And as I've sat through, at least I've been here for two presentations, the two presentations I've been through have talked a lot about analytical phase of testing, right? The sideline reporter, Dr. Jerry Puncher, whoever. I'm going to be talking, I think, a lot about the pre-analytical component, like this. So my message is that you really should be thinking about what you're offering before you get to that stage. So that's one of my take-home messages. All right. With that said, my outline with respect to syndromic molecular panels, I will first describe what are they, secondly, why are they beneficial, and then how does critical thinking enter this conversation. And I have no disclosures to tell you with respect to this presentation, and I will try to keep my lingo on the generic side, not to espouse or diss a certain product too much, okay? First of all, what are they? So the slide I'm showing you right now is one half of a slide that I present to our physician assistant students at Marquette when I discuss what a molecular or syndromic panel is. So these guys simultaneously test for multiple pathogens on the basis of site of illness. It's kind of like a shotgun approach, as some people may call it. But one advantage of these syndromic panels is that they can encompass multiple aspects or disciplines of microbiology. And I'll show you some examples of these layers. They can range from bacteriology, mycology, virology, or a combination thereof. So commentaries have been written about the value or questionable value of syndromic panels, molecular syndromic panels. And one commentary wrote that infectious agents of the same organ system, though some agents may have different clinical manifestations. So in other words, we can test for a whole variety of things from a general organ system, but there may be slight differences in disease manifestations. Another commentator wrote, we've been doing this all along. We've been doing syndromic testing all along. Your urine culture is essentially a syndromic test, right? Your blood culture, you don't know what's in there, but we're just going to grow it anyway. So we're treating these as syndromic tests anyway. Without a diagnostic approach, we would have to treat for everything. We'd have to manage for maybe yeast, we'd have to manage for bacteria, gram-positive, gram-negative. So the syndromic approach may help narrow down what has to happen as far as therapy. And without a panel approach, without consolidating this thing, clinicians may be ordering 55 different PCR tests on the same specimen. So a panel approach may help in consolidating the diagnostic approach. All right, I'm going to discuss in various forms 4 types of syndromic panels. And the first one, you all know what this is, but I'm just going to call this a meningitis encephalitis panel. And the advantage here, and this is an all-star lineup of clinical microbiologists who have published this first study. We have bacterial agents of meningitis encephalitis. We have a yeast one, especially in the context of HIV/AIDS. When you have your AIDS-defining illness, half of your AIDS-defining illnesses can be involved in cryptococcal meningitis. And then you have a whole slew of viruses involved in this commercial molecular syndromic panel. Second one I may bring up is a respiratory virus panel. And again, I'm not going to tell you who this is from, but this is one of the first published molecular syndromic panels, published in JCM in 2008. Covers a variety of respiratory agents of illness. I will note at this time there are also pneumonia syndromic panels that have come about after this one has been published. Thirdly, I'll talk a little bit about blood culture identification. In other words, a positive blood culture bottle, we can identify the agent that might be involved, as well as some important resistance mechanisms, such as MEK-A, VAN-A, VAN-B, and some of those carbapenemase resistance mechanisms. And recent data have suggested that the presence of a certain carbapenemase may actually be able to steer physicians away from certain antimicrobial modalities, including those combination third and fourth generation cephem agents linked with the beta-lactamase inhibitors, or steer people away from those carbapenemases, some of the carbapenemases that are also linked with beta-lactamase inhibitors. So these panels might be important, and this paper allows me to say, you bet your ASP, right? I'm fired up to say that. ASP stands for Antimicrobial Stewardship Program, right? So I'll show you data a little bit later that suggests that performance of these panels is really tied in well, or most beneficial when it's tied in with the whole you bet your ASP paradigm. And then we will talk about molecular panels dealing with gastrointestinal agents. Here's another one that combines bacterial agents in green along with viral agents in yellow, and now we're adding parasitic agents in lavender or pink or whatever that color turns out to be here, okay? And then toward the end, I'll surprise you with one additional type of molecular panel. And warning, I may go on my soapbox when I talk about that a little bit. Okay, so you're forewarned. Here we go. Eye clicker question number 1. Get your eye clickers out. And hopefully Erik can remember what Aaron told him literally 5 minutes ago. Here it is. Does your laboratory offer syndromic molecular panels on its test menu? A, no, we don't. B, we don't, but we want to. We're thinking about it. C, we offer one or two of the tests that Erik just talked about. And remember, we have blood culture ID, respiratory virus panel, GI panel, and meningoencephalitis panel. D, yes, 3 to 4. E, I'm scared about what Erik's going to talk at the end. So do I go A here? A starts the voting. All right, here we. Oh boy, everybody knows their answer. That was quick. Everybody's hungry. That's why they voted so quickly. B for the results. 3 to 4. So it looks like a lot of us are on board. Either 30%, 1/3 are doing 1 to 2, and 6. So over 90% of us are doing syndromic panels, and no one is scared of what I'm going to talk about at the end. That's good news. Okay, so how do I get out of this now?
So did the A and the B again.
A and the B. A and the B again? Okay, I just undo what I did. Okay, great. All right, so when you're dealing with a complex situation, I always think back to Leslie Knope on Parks and Rec, when she was the assistant director of the Parks and Recreation Department at Pawnee, right? If she had a tough situation, she would always make a pros and a cons list, right? So we're going to make a pros and a cons list of molecular syndromic panels for the next couple minutes. So benefit number 1. Perhaps identifying unknown outbreak situations. So here is an MMWR article published in 2015 that talked about a respiratory illness in late summer of 2014 in the Missouri and Illinois area. And it was a late summer, and as we know with our virus prevalence panels, right, virus incidence panels, there can be some overlap with respect to some of the viruses in that part of the year, right? So they cited or lauded a molecular syndromic panel as helping them to identify a whole slew of enterovirus infections during that time of year, and they further subtyped as an enterovirus D68. And they credited the syndromic panel approach to help them narrow down to an enterovirus, and then they could further investigate. Other authors have suggested that using molecular syndromic panels can rule out a whole bunch of other things, allowing diagnosticians to target something else. So the rule-out approach may be additionally helpful in identifying an unknown outbreak type of situation. Benefit number 2, let's talk about central nervous system disease, so your meningitis or encephalitis syndromic panels. So past FDA clearance, and this is a few years back, of course, was limited to enterovirus detection or herpes simplex virus detection. But then you get that panel that I talked about before, and a paper was published regarding 145 neonatal specimens that identified an additional 17 pathogens by the panel. So no-brainer, right? We have more agents on the panel. We have the ability to identify more. And parechovirus was one of those newer agents incorporated on those encephalitis panels that led to higher detection rates. Another thing that was mentioned is provider satisfaction, right? These providers, even at your non-tertiary care hospitals, remember these are FDA-cleared panels that are commercially available. They can relatively easily be incorporated into clinical practice, which could be a big satisfier to your clientele or your providers. Benefit number 3, a patient satisfier. So Dr. Schreckenberg wrote a commentary regarding this relative to a respiratory virus panel. He noted in that commentary that when you go to the ER, you're typically not there if you have a runny nose or the sniffles, right? The patients go there because there seems to be an acuity of illness. They're really down in the dumps. They really think they're sick. They want an answer, right? So some of these panels take 1 to 2 hours. Of course, if your laboratory staffing allows that to happen, they can get the results pretty quickly and dispatch these people with some sort of diagnosis. The patients are happy. And Dr. Schreckenberger noted that sometimes this may lead to surveys documenting patient satisfaction, which may actually increase the business within your healthcare type of setting, because healthcare can be competitive in large metropolitan areas. Benefit 4, patient management. Again, we're going to deal with central nervous system disease here. So higher fatality rates associated with bacterial meningitis versus viral meningitis. So nailing down a diagnosis by way of a syndromic panel of a viral agent of meningitis may not be as quote-unquote serious for a patient as with a bacterial meningitis. Also, listeria is incorporated, if you remember a few slides back, on that molecular encephalitis panel. Now, when patients are coming to the big house or the ER with a suspected meningitis, they're going to treat them empirically, right? For serious illness with like a 3rd-generation Cephem and vancomycin. And going back to your education days, what does vancomycin do to listeria? Not much, right? Because it's one of those 4 PEL organisms that are intrinsically resistant to vancomycin. And then if you look at your CLSI book, listeria is inherently resistant to your Cephem agents. So if you're able to identify listeria on your molecular syndromic panel, that would cause the clinicians to add ampicillin to the treatment regimen to cover for that agent, because that's the drug of choice. All right, I won't go through everything on these slides. Also related to management is length of stay. So here's where the bean counters get involved, right? Hospital management, financiers, all sorts of stuff like that. So viral agents of meningitis, for the most part, have lower severity, which means that if you get a diagnosis by way of syndromic panel of a viral agent of meningitis or aseptic meningitis, therapeutic interventions may not be as necessary as they would for bacterial meningitis, right? And as a result, studies have shown that the length of stay can be reduced to a lot shorter period versus bacterial meningitis with the intervention or with the diagnostic modality of a molecular syndromic panel. And in one neonatal study, it looks like it cut down that length of stay by 24 hours. And when you're talking about new parents with a neonate, they feel better getting their Hanyak youngsters home quicker than having to stay in the hospital. And I can speak to that from personal experience. All right, and then benefit number 5. This relates to our blood culture ID, quote-unquote, syndromic panels. And I always like to use this example in my classes with respect to MRSA versus MSSA. And again, back when you're coming to the big house or the ER with septic picture, right, they're going to treat you empirically with vancomycin and probably ceftriaxone or cefepime. Now, according to just basic lab knowledge, right, vancomycin should work against both MSSA and MRSA. But a study out of the VA in Idaho a number of years ago demonstrated that patients who are bacteremic with MSSA respond more poorly to vancomycin than they do nafcillin, right? Even though in vitro, vancomycin should work on everything, clinically, they did not respond to vancomycin. And they actually responded better with nafcillin. And when they did in vitro experiments doing growth curves and stuff like that, growth rates, here's your positive control for growth. Here is the MSSA treated with vancomycin, and here's the MSSA treated with nafcillin, right? Again, suggesting an in vitro correlate with the in vivo clinical response that nafcillin has better killing activity against MSSA. Why do I say this? If you have a blood culture panel, positive blood culture panel that can detect MECA and ORFX or whatever you guys are using nowadays, if you detect MSSA in your bloodstream infection, that allows pharmacy, remember you bet your ASP, it allows pharmacy to make that intervention to switch from empiric vancomycin to nafcillin with the better killing activity and the better patient outcome. So that's another advantage. And then finally, benefit, I guess it might be number 6 or 5 or whatever, intervention, right? So getting to your GI, this is a GI panel type of situation, right? We're looking for bacteria, viruses, and parasites so that molecular panel can identify the salmonella from your church picnic, the shigella from your daycare outbreak, the norovirus from your cruise ship, the cyclospora from your quick trip lettuce, and whatever that Taco Bell worker is going to give you, right? So that's quicker intervention, public health intervention on the basis of a wide expanded panel. So there are definite benefits to those syndromic panels. So then the Leslie Knope cons list. So how does critical thinking enter this conversation? Let me give you a couple examples about that. Are we okay on time? You're going to cut me off, right? Good, okay. So here's the remainder of that slide I showed to the Marquette PA students when I come talk to them. Syndromic panels can be rather expensive. Laboratories worry about reimbursement. I'm not going to get into that because there was a webinar in January from Dr. Yao that talked about that. And difficult for laboratories to validate tests. And some of you are already smirking in the audience, right? So let's go back to our GI panel. And I won't mention who makes this, but here's a comprehensive GI panel for parasites, viruses, and bacteria. Okay, looks great. Here are some data. We're faking a patient result here, and it looks like they're positive for norovirus, right? They were involved in Hurricane Katrina, or they went on a cruise ship, or they went down to Florida State to play a football game, whatever. So here's another situation that may come about in your practice where you still have a positive norovirus, but then OMG, we have a positive result for Clostridioides difficile toxin, which I think leads me to my next iClicker question. Yes, iClicker question number 2. Get ready. Oh, shoot. Oh, no.
No, just hit it again.
Okay. Here's the question number 2. What do you do when your multiplex GI panel detects C. diff toxin along with an agent of gastrointestinal illness? A, report them both out, because that's what the instrument told us. B, report out the most likely culprit of the two. And by the way, you have to tell me which is the most likely culprit when you answer that. C, call a provider, have a chat about it. D, this never happens to us. And E, send an email to the inaugural winner of the Schultz Award, who is the gentleman sitting right in the middle. Okay, so let me open up the polling here. Here we go. And by the way, congratulations to the second winner of the Schultz Award, whoever that person is. People are really thinking about this one. Maybe they're less hungry. Maybe they had a snack. All right, we're stagnant at 31. So I will... Results. Okay, we have about a third of us reporting them both. We have about another third of us calling the provider to hash it out. I think that's a reasonable. And again, there's no right answer to this, except for the people who answered E. That is definitely a correct answer. So send Ray an email and he'll tell you what to do. Okay, so then, let's move on if I can figure out how to do this. Okay, so this is Dr. Alex McAdam, who's the editor-in-chief of Journal of Clinical Microbiology. So instead of what would you-know-who do, we're going to ask what would Alex do in this situation. So he wrote a commentary regarding GI syndromic molecular panels, and in his commentary he kind of put out a scenario or a hypothetical. Would you recommend routine simultaneous testing for the following combinations of pathogens? And he had three bullet points, one of which were stool samples for C. diff in combination with norovirus, salmonella, campylobacter, and Shiga toxin-producing E. coli. So this situation has been out in the literature, right? So here's his response to that situation. He advises folks to consider your patient population, right? So C. diff might be related to age, previous antibiotic usage, maybe a current hospital admission, maybe some other factors, iatrogenic factors, or GI tract manipulation. Dr. Alex also noted that only a minority of patients need both tests, right? Testing is indicated for both C. diff toxin as well as other GI agents in only a small minority of individuals. And the big thing to remember here is that there can be colonization of C. diff. In other words, C. diff can be normal flora in a large number of us. In addition, some of us have toxinogenic C. diff as normal flora without diarrhea, okay? So you need to consider those factors when sort of managing that type of test offering. One thing you can also do in the pre-analytical or pre-game show sense is take measures to ensure that the proper specimens are getting to your laboratory, right? And if you look closely, Tim Block, one of our previous presenters, is one of the authors on this study. So this is a situation where if you look in the B panel, this is a C. diff PCR test, a tox A C. diff PCR test that was experiencing rather high, let me get my pointer, sorry. That was experiencing rather high detection rates in this laboratory. And this is a centralized laboratory that did testing for, 5 or 6 different hospitals in a certain part of Wisconsin, right? So experiencing high levels of positivity rate for C. diff tox A, right? And of course, we want to prevent this from happening. This is pseudomembranous colitis in someone's intestine. So with those high percentage rates, infection control did some digging, and it turns out that a lot of poops were being sent to the laboratory from patients who had quote-unquote diarrhea from laxative usage. And some of you in the audience are going, oh yeah, I know about this situation, right? So they think they're having diarrhea from inpatient hospitalization when in fact, it's actually diarrhea from laxative usage, right? But these laxative usage situations were not being charted or placed in the patient chart, and the primary care provider didn't know about laxative usage, right? So there was an electronic intervention that was placed into the LIS, or actually the hospital information system, that prompted the clinicians to answer the question, is this patient on a laxative? If the answer is yes, they would not allow you to order the C. diff test without further consultation, right? So it's sort of a checkpoint on that. So the intervention happened about here, and the C. diff detection rates subsequently statistically went down after that point. So in other words, the laboratory was generating more clinically relevant C. diff PCR results on that patient population. Now the SIR, do we have an infection control practitioner in the house? Okay, a SIR is sort of a standardized infection rate, so that's essentially your nosocomial transmission rate. And if you're in good, and by the way, they stratify it based on your hospital size and hospital location, so that apples are being compared to apples, right? So if you're in good shape, your SIR rate should be about 1. And obviously in this situation, before the intervention, the SIR rates were out of whack. And the hospital bean counters don't like that because you're denied reimbursement in certain situations when your SIR rates get too high. But with the result of that intervention, those SIR rates went down to an acceptable state. So again, another example of how the pregame show or pre-analytical considerations can help in your management of your molecular testing, including your syndromic testing. All right, I'm putting this slide up as a sort of a launching point for a discussion about the meningitis encephalitis panel. So many of you know this already, we see a lot more aseptic meningitis or viral meningitis in the United States versus bacterial meningitis. It's actually a very rare condition. Here we go back to that original study full of microbiology all-stars talking about that meningoencephalitis panel. Let's take a look at how that study was generated for a minute, okay? So they got all the all-stars together because they wanted to have a large number of samples, right? In order to really try to validate a panel, especially one that's expanded or very, very multiplex in nature, you gotta have a lot of specimens, right? So they recruited 11 US medical centers over an 8-month period. They got over 1,500 specimens. They used culture as the reference standard for the bacterial components of the panel, and then they did individual, either FDA cleared or homebrew PCRs to assess the presence of viruses and yeast. And overall in the study, they had a 9% detection rate, but sort of look how it was slanted. I mean, this is a prospective study. They didn't do this on purpose, but it seemed like they assessed a lot more viral agents of meningoencephalitis than they did bacteria and yeast. When you look at the detection rates, so the blue lines are the concordant results. That means that the panel, syndromic panel, jived pretty well with the reference method. And then the bars in red means that the meningoencephalitis panel was quote unquote falsely positive. It didn't match the reference result and was considered falsely positive. And the green bars indicate that the meningoencephalitis panel missed something that the reference method got. So overall, the authors report 90% sensitivity for most analytes and 99% specificity when all analytes were combined. But notice on some of the coloration, there appeared to be some deficits within that panel, especially related to Streptococcus pneumoniae. It appeared that more strep pneumos were being called or falsely being called on the meningoencephalitis panel than would be on a reference culture method or something like that. So they attributed it in part to potential contamination from the user seeping into the specimen during the processing of the test, right? But if you go back to your experience with these old school antigen tests, sometimes your Viridans group strep can trip a positive strep pneumo antigen test. And we're speaking way from like 20, 30 years ago. So there is the potential for that to happen as well. But it does appear from this study that strep pneumo may have a problem in this meningoencephalitis panel. Okay. Another commentary addressed this paper and noted potential deficiencies in how they did this study. So of the 14 targets on that molecular syndromic panel, only 3 of them had at least 10 positive specimens to assess, right? So we're talking low numbers, really hard to make a proper assessment of something when you have such low N values. So they were questioning that. And then as a comparison, this author mentioned that with respect to a GI syndromic panel, of the 22 targets, at least 16 of those had a good solid N value of at least 10 specimens. So that's a potential deficiency of that. Then they also noted that of the viral agents detected, a couple of them had sort of sketchy clinical significance. So HHV6 was pretty commonly detected in that study, but at the same time, HHV6 is commonly encountered in childhood, and it could incorporate itself into normal tissue. So it's almost sort of a normal flora virus, and I'm using very specific quotation marks on that, right? So the clinical significance of a positive HHV6 or human herpes virus 6 could be called into question. Similar story with CMV detection in the meningoencephalitis panel. CMV is a high seroprevalence virus. We talk about that with respect to pregnant women, but it can have latency inside of white cells. So if there's white cells being collected in lumbar puncture, there may be some CMV within those white cells that could trip a result that may not be clinically significant for your patient. And then the commentator finally mentioned something about general prevalence. So let me give you some lab math to really fire you up close to lunchtime. So lab math, the 2 values that clinicians really, really want to know about, the real doctors, not me, the real doctors want to know is about positive predictive value and negative predictive value. They're not so fired up about specificity and sensitivity. They want to know how a test would work in their patient population. So that's where those predictive value parameters would come into play. So everybody remembers these equations, right? Now I will tell you that predictive value is largely impacted by true positives, how much prevalence of disease you have in that population, right? If you have some false positives, those false positives in the denominator can be mitigated by a large prevalence, a large number of true positives. So how could this hypothetically play out in the meningoencephalitis panel? Just for funsies, we're going to take a test with 87% sensitivity, and like Tim Block says, we're not going to memorize these numbers, 87% sensitivity and 90% specificity. And for funsies, we're going to test 1,000 people. The first 1,000 will be tested in a test prevalence of 20%, so a high prevalence population, and then we have 2% prevalence in a second example. Look what those differences in prevalence for the same assay parameters does to the positive predictive value. It lowers it tremendously, right? Now the second example over here was 2% prevalence. Prevalence of aseptic or viral meningitis has been estimated at like 0.02%. So we're way the heck down there, right? Which could do pretty nasty things to your positive predictive value. So keep that in mind when potentially assessing some of this literature. Kim Hansen, in another commentary, noted that the gram stain is still essential for interpreting PCR results. The panels may not get everything that's targeted. In other words, the panels may not be designed to pick up every agent that could be involved in meningitis. Cryptococcal antigen testing from serum and spinal fluid is still very good for cryptococcal meningitis. So her point was that, yeah, molecular panels are great, or syndromic panels are great, but they may not be the end-all. They may not be a replacement for your conventional microbiology. All right, couple of words about the blood culture panel, right? The you bet your ass part, right? So when I just realized today that I put the bean counter slide first when I probably should have put the bean counter slide second because we're into science. But so the positive blood culture story, a couple of abbreviations. First of all, MRDT, that is a molecular rapid diagnostic panel. ASP is antimicrobial stewardship panel. All right, that's about all the abbreviations we need here. Now the metrics, or the y-axis. The y-axis is some sort of crazy amateurized figure that talks about savings per death averted. Essentially what this means is the higher the bar, the better it is. All right, let's just go with that. So savings per death averted, the higher the bar, the better. So the higher bars were noted in this meta-analysis when you had molecular rapid diagnostic testing off the positive blood culture bottle with an antimicrobial stewardship program. And the best comparator here for this bar is probably this guy over here, right? So you're really only going to get a significant benefit of a positive blood culture ID is when you tie this in with pharmacy or your friends in pharmacy, right? And there's been a lot of papers within the last 10 years that have talked about this. Now, with respect to what we care about more, and that's probably mortality due to sepsis, right? So the bean counters are out for now. This meta-analysis looks at mortality risks and expresses it in odds ratios plus or minus 95% confidence interval. So if anybody remembers odds ratios, it's even Steven when you're at 1. In this situation, if you're less than 1, there's less mortality, and if you're above 1, there's more mortality, right? So look at the odds ratios of molecular rapid diagnostic testing versus conventional microbiology. There's a benefit, right? So adding these panels versus just doing the subculture ID and susceptibility testing does appear to have a benefit as far as mortality is concerned. But when you link this or match this up with stewardship, there is a better mortality or an improved mortality rate. Notice that these confidence intervals fall below 1, whereas if you don't involve antimicrobial stewardship committee, your error bars kind of slither over the 1. So again, the biggest benefit of doing these positive blood culture ID panels, syndromic panels, is when you tie it in with your pharmacy friends. How are we doing on time?
We have 15 minutes.
Oh my gosh, we're gonna get this done. Okay, so the surprise, okay? So the surprise is I'm going to spend a couple minutes talking about STD molecular syndromic panels, right? Some of you are shocked that I'm going to be talking about STDs, but here it goes. So the first STD I'm going to mention is Mycoplasma genitalium. And yes, I will use the original names, not the new names, okay? So here is a clinician feedback. We had just introduced the Trichomonas molecular test in our laboratory a few years later. And we have the director of a local STD clinic in Milwaukee saying, you know, ever since we started doing your new trick test, we still notice guys with obvious urethritis, but still have negative results, and these are molecular results, for chlamydia, gonorrhea, and trick. I really think this is mycoplasma. Can you test for this? So what does any director do when they hear this story? Well, they might go to the literature to kind of check this one out. So what's been published about molecular testing for Mycoplasma genitalium? So the obvious first place, besides Tim Block's Google that he mentioned before, might be something called PubMed, right? So PubMed, great repository of clinically relevant microbiology literature, but I'm going to warn you in the next couple of slides, you really have to be careful about what you read. Sometimes what is published and what is PubMed may not actually be appropriate to your situation. Lana's kind of shaking her head. Yeah, she agrees with that too. All right. So here's one cautionary tale. Here's one paper published in Journal of Infection and Chemotherapy that looks at a multiplex test for STI agents, and we're including chlamydia, gonorrhea. There's our Mycoplasma genitalium, ureaplasma, Mycoplasma hominis, and Trichomonas vaginalis. Okay? So here's a study done by a group that shows the data right here. Now what's interesting about this study, and you got to read the fine print about this, this is one manufacturer's diagnostic multiplex panel, and they are testing it against their own products, but singly, right? So it's a multiplex panel developed by company A, but they're using the reference method as individual panels from company A. So, not shockingly, they got no discrepancies in their study. And yes, this is a published paper, right? So no discrepancies at all. The 2x tables look fabulous, right? So no discrepancies. So they're preaching to the choir that their test works great because of the reference method that they selected for their adjudication. Here's another study that looks at a molecular syndromic panel for STDs once again. I don't know if this one made it to market. I don't think it did. But it's not because of this paper. I just don't think it made the market, okay? So here's a multiplex panel for STI agents. And there are some agents, here's the panel that they're looking for. Some of the agents had no reference method at all. So they're publishing this paper without any sort of reference method for detection of Mycoplasma genitalium, ureaplasma, ureolicum. And then if you look further in this paper, you look at the number of specimens they tested in this paper. They have Haemophilus ducreyi in the panel, but they did not assess it at all. They had no specimens. They didn't even try to fake or simulate a specimen for that one. And you also notice low numbers for Mycoplasma genitalium and Trichomonas vaginalis. And we know nowadays there's tons of Mycoplasma genitalium out there. So sometimes these papers are not, sometimes these studies are not constructed in the optimal way. We'll just put it that way. Okay, here's another paper published in a Scandinavian journal that looks at Neisseria panel, chlamydia, Mycoplasma genitalium, and Trichomonas vaginalis. Now here are the 2x2 tables, so let's focus on this area right here. So this is a positive reference result with the manufacturer's negative result. Here is the reference result of negative with the manufacturer's result of positive. So these two areas right here, here, are looking for discrepancies. And usually, if your method is pretty good, these diagonal numbers should be about the same, right? You should have about the same number of false negatives as you do quote-unquote false positives. But there seems to be a preponderance of missed results by this assay compared to the reference result. So that sounds a little bit fishy to me when you read stuff like that, as far as the quality of the assay. And then the other thing you have to worry about when you're reading these papers is the reference method they're using, right? Sometimes you may encounter a novel new method in which the authors actually report a preponderance of false positive results because the positive result by the assay does not match the reference standard. It may turn out that your novel test may actually truly be more sensitive than the reference method and may eventually be called an evolving reference standard, right? So watch out for your false positive results and make sure you're properly comparing them to a reference standard to get a true sense of whether or not it's a false positive or perhaps an emerging better test method. All right, iClicker question number 3. Everybody wake up for this one. All right, here we go. Does your laboratory test for organisms such as genital mycoplasma hominis or ureaplasma ureolyticum? A, yes, we routinely do so. B, yes, but we don't test it very often. We don't get that many requests. C, we don't offer this testing. D, yes, sort of, but we send it out. And then E, I need more pastries. I think there are still some back there. So let's open the ballots. It is election day. I didn't plan that, but it is election day. All right, that's pretty good. Well done. And let's look at the data. Let's look at the data. There we go. It's a send-out test for 3/4 of you. And let's see. And about 10% of us routinely do it. So not many people do this test. So this may not be completely relevant to you, but we're going to talk about it anyway. All right. All right, molecules. So taxonomic tree, this is class molecules, right? Class is above order, above family, yada, 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 right? So here is a summary of Mandel's infectious disease textbook talking about male genital disease. And yes, ureaplasma ureolyticum can cause non-gonococcal urethritis, but the proportion of ureaplasmas causing that infection is unknown. And BTW, Mycoplasma hominis, does not cause urethritis. So you go down the list and you see sort of a variety of clinical conditions which can be caused or associated with ureaplasma infection. And then Mandel goes on to talk about this with respect to female populations. And once again, note that Mycoplasma hominis does not cause cervicitis. Ureaplasma does not cause cervicitis. What is most of our routine STD testing doing in the laboratory from ERs and OBGYNs? They're looking for cervicitis and urethritis, right? The problem is that a lot of newer assays, syndromic panel assays, are starting to include Mycoplasma hominis and ureaplasma on their panels, which could give, I'll go through today in a little bit. All right, so STD treatment guidelines. This was a huge document published by CDC in 2021, and a lot of Geek Squad STD people got really excited when these guidelines came out. So they talk about diseases caused by urethritis, or diseases associated with organisms associated with urethritis and organisms associated with cervicitis. If you go through the fine print, get down here, data are inconsistent regarding other mycoplasmas other than genitalium and ureaplasmas as etiologic agents of urethritis. So their CDC is essentially telling you that hominis and ureaplasmas do not cause urethritis. Similar story with cervicitis. Let's see, where do I have this? Testing for ureaplasma parvum, ureaplasma ureolyticum, hominis, or group B strep is not recommended in the context of cervicitis. Yet, if you look at some of these offerings in diagnostic syndromic panels, these agents are incorporated into some of these panels. So the more likely association with hominis and ureaplasma comes in the context of pelvic inflammatory disease. And again, that's often a tissue type of specimen. It's not your general urogenital swab specimen that's looking for pelvic inflammatory disease. And it's close to lunchtime, we'll skip that one. All right, here's some data from about 10 years ago. This was that original syndromic panel that I talked about at the start of the STD portion of my talk. And notice that they had 82 detections of Mycoplasma hominis within this study. And again, this was a combined urethritis and cervicitis study. Those 82 detections of hominis may not be clinically useful to your clientele, but this assay still has the analytes on them and they're still detecting them. Now, our laboratory actually did a funsies study of male specimens looking for ureaplasma ureolyticum in comparison to chlamydia, Mycoplasma genitalium, Neisseria gonorrhoeae, and Trichomonas vaginalis. And notice the percentage detection rate, which is going to lead me to iClicker question number 4. And I promise this will be my last one. Other than at the height of your SARS coronavirus 2 powers or peak respiratory season, do you have a molecular test that exhibits more than 22% positivity over a continuum, over a long period of time? Not just peak respiratory season, but what do you think? A, no, we don't. B, no, but Eric, you have a problem with your test. C, yes, we see those. D, yes, and I'd love to tell you about it. And E, I want to go to lunch. We'll see how many people say E. I bet you'll be a lot. So let's open the balloting. Oh yeah, everybody's answering E because the responses are coming quick. They're coming quick. All right, let's shut it down. Only 20% of you want to go to lunch. So the answer is no. Yeah, and that's my point, right? It's very, It's very unusual, even in highly sensitive, analytically sensitive molecular testing, to have a single analyte generate that high of a percentage. So how does this apply? European guidelines published even before the CDC guidelines, and again, Europe is way ahead of us as far as STD testing, right? So even for the last 5 years, Europe has been strongly discouraging testing for Mycoplasma hominis, ureaplasma, whatever, in the routine testing. Again, this is cervicitis and urethritis screening. And yes, they detected, and they mentioned in their paper that asymptomatic carriage is common, just like those ureaplasma data I just showed you, but they're not clinically significant. And in fact, extensive detection, maybe those wacky syndromic panels, and treatment may introduce economic burden, especially to female populations. So my take-home message, I'm just about done. Benefits, yes, they do exist with the syndromic molecular panels. And again, I'm not trying to preach law and gospel. I'm trying to give you a story of both sides. Limitations do exist, as I mentioned toward the latter half of my presentation. Please try to review the literature with a critical eye. Just because it got published doesn't mean the study was either developed or executed in the proper way. And hopefully review boards try to catch this, but sometimes some of these papers slip through the cracks. And then my last point, don't offer a test just because you can. Determine first if you should. All right, and that's it for me. Time for lunch.
All right. All right, does anyone have any questions quickly before we do go to lunch, or anything to share about using these syndromic panel tests and critical thinking where they've had issues or? No?
Everybody's hungry.
We're really good with those. Okay.